Hello and welcome to the ASCO Guidelines podcast series, brought to you by the ASCO Podcast Network, a collection of 9 programs covering a range of educational and scientific content and offering enriching insight into the world of cancer care. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. Dwight Owen from Ohio State University in Columbus, Ohio, lead author on Therapy for Stage 4 Non-Small Cell Lung Cancer Without Driver Alterations, ASCO Living Guideline version 2022.2. Thank you for being here, Dr. Owen.
Thanks very much, Brittany, for having me.
First, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The full conflict of interest information for this guideline panel is available online with the publication of the guideline in the Journal of Clinical Oncology. Dr. Owen, do you have any relevant disclosures that are directly related to this guideline topic?
I have research funding to my institution to conduct clinical trials from several companies, including Merck, Pfizer, Genentech, BMS, and Pella Biopharma, but no ownership, no stock, and no employment history.
Okay, thank you for those disclosures. Then let's get into the content of this Living Guideline update. So this is the first update to the Living Clinical Practice Guideline for systemic therapy for patients with stage 4 non-small cell lung cancer without driver alterations. What new evidence was identified by the routine literature searches to prompt an update to the guideline?
Yeah, so this is a really exciting time for patients with stage 4 non-small cell lung cancer. We are anxiously awaiting the results of some ongoing immunotherapy combination studies. However, for this update, we focused on a specific paper and study that evaluated a treatment that is not our first option anymore, but maybe the first option for a subset of patients. So before the standard introduction of immunotherapy for patients with stage 4 non-small cell lung cancer, we often offered platinum-based doublet chemotherapy. And for years, we studied ways to make that better. So we might introduce maintenance therapy, where we continue a treatment after the first line of induction chemotherapy. We did either continuation maintenance, which is where you continue a treatment that seemed to be effective, or switch maintenance, where you introduced a new therapy. For many folks with non-squamous non-small cell lung cancer, the standard treatment options included carboplatin or cisplatin with pemetrexed, which is an antifolate chemotherapy, or carboplatin and paclitaxel with or without a VEGF inhibitor such as bevacizumab. One of the big questions was whether there was a benefit for continuing maintenance therapy with something besides pemetrexed, in this case bevacizumab, and if bevacizumab was given in combination with pemetrexed, whether continuing that as a maintenance would offer benefit. Now, it's important to point out that the current FDA approval, at least in the United States, is for bevacizumab to be given with carboplatin and paclitaxel. However, several studies looked at the combination with pemetrexed, and there were several issues with those studies. So in one study, they used a different agent, so ramucirumab instead of bevacizumab, both VEGF, but slightly different. In one study, the combination that was compared of pemetrexed plus bevacizumab was only compared to bevacizumab maintenance. And so we really had a sort of hodgepodge of different trials that never answered the question of whether bevacizumab or VEGF therapy given as maintenance offered any benefit to our patients. What Dr. Garin and co-authors did in a study that we evaluated was conduct a meta-analysis of 4 of those randomized trials, focusing on the question of comparing pemetrexed maintenance therapy alone versus in combination with bevacizumab. And what they found is that there was no significant difference in overall survival with the addition of bevacizumab compared to pemetrexed by itself. And there were higher rates of toxicity in those patients, including serious and higher grade toxicities. So we felt that it was really important to point out that the addition of bevacizumab or other VEGF therapies does not seem to add to a survival benefit when given as maintenance. And even though this is a subset of patients who perhaps could not get immunotherapy as a first-line treatment, maybe because of a pre-existing autoimmune disorder, but for those patients, it doesn't seem that the addition of VEGF as maintenance offers what we were hoping for.
Understood, and I appreciate you laying out the landscape of the data in this area. So then based off this new data and the meta-analysis that you just described, what is the updated recommendation from the expert panel?
So the updated recommendation is a tweak to the established recommendation, which is essentially that for patients who are not candidates for immunotherapy for any reason, that platinum doublet chemotherapy is really the mainstay, and that if maintenance is offered, that it should not include a VEGF therapy in combination with pemetrexed as compared to pemetrexed by itself.
Understood. And then what should clinicians know as they implement this updated recommendation?
So I think, again, this should be a relatively uncommon scenario. Most of our patients are candidates for immune therapy. Many patients are offered platinum pemetrexed by itself. But when thinking about continuing maintenance therapy, we would recommend that most clinicians avoid the addition of therapies that haven't seemed to offer a survival benefit and incur higher rates of toxicity.
Great. That's helpful to know. And then you've just mentioned that this doesn't apply to a lot of patients, but what does this change mean for patients with stage 4 non-small cell lung cancer without driver alterations?
Yeah, so I think hopefully for the subset of patients where we're really thinking about here, that we can at least avoid additional toxicity if there isn't a trade-off in terms of benefit, in terms of survival.
Great. Definitely. That's helpful. And then finally, what ongoing research is the panel keeping an eye on for future living guideline updates?
So there are a lot of exciting trials that are ongoing and hopefully we'll be able to read out soon that would offer us updates for really how to manage these patients in the frontline setting with stage 4 non-small cell lung cancer. We have multiple options now. This discussion that we've had today really focuses on the pre-immunotherapy era. But of course, bevacizumab is utilized in a regimen along with carboplatin, paclitaxel, and atezolizumab compared to monotherapy with checkpoint inhibitors, compared to chemoimmunotherapy and dual checkpoint inhibitors. And we don't really have any head-to-head trials yet or strategies on how to identify which patients need more aggressive combination therapies versus which patients could potentially do without chemotherapy or with single-agent checkpoint inhibitor by itself. So while we wait for those studies, like the ECOG and SIGNA study, we're really looking forward to having those to be able to help decide and tailor our treatment options for our patients.
Great. Well, we'll look forward to the ongoing review of the literature by the panel and any future guideline updates to recommendations in the meantime. So thank you so much for your work on this update, and thank you for your time today, Dr. Owen.
Thanks for having me.
And thank you to all of our listeners for tuning in to the ASCO Guidelines podcast series. To read the full guideline, go to www.asco.org/thoracic-cancer-guidelines. There's also a companion living guideline update on therapy for stage 4 non-small cell lung cancer with driver alterations, available there and in the JCO. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, available in iTunes or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.